be more like a discussion rather than anything else. Well, thank you for everybody who has actually come along today. I did put a plea out for people if they had any experiences to share, please. I would be delighted to kind of join today. And Lucy kindly said that she would, but yeah, I didn't have any others. What I thought I would do is go through what we do. We've taken students for a number of years now, and it's been an evolving process. And I've also had some discussions with our local university about what can happen in a placement and what they are okay to have as a placement. I also contacted the CSP to ask from them what their guidance was, but I didn't actually get any response. But that was at the end of last week, so maybe they haven't had time to respond to me. I'll give them a little bit of wriggle room there, but maybe on the back of today and any other input, we can put something more formally to them if we have any queries or questions from there. Because I think in Frontline they are seemingly in discussions with the Royal College of OTs, NHS England. And they want to engage with independent healthcare to look at what are the opportunities for students on placement. So I do think this is a hot topic. It does inform then recruitment, or can inform recruitment from there, and I think it's something that is going to have to evolve as the training of the physios starts to change. So what does it look like for students with us? So what we get numerous, we get a couple of different universities that will approach us for student placements. And what we have started to do is we ask any students who would like to come to us in placement to complete an application form. So basically what we want to see is what are their intentions on graduating. So if they just want to tick a box and come on placement, we're really not that interested in putting the time in. If they are interested in private practice following graduation, and MSK is a big driver of theirs, then we will seriously look at them. And we also kind of look at people that are potentially going to come to our practice as well. Because if we're putting a lot of time and effort in, we know we won't get return on every single student, but we would potentially like to see some return in that carrying over into our workforce later on. So this is new with us, this application. So we ask them to complete an application form. It's mainly elective students that we take rather than other student placements, and that's basically because of the administrative workload that goes with that. So our elective students for the placements, our local university, we've got to complete a midway and a final, and we just ask their supervisors to do that in a free slot so that it's not costing us much more money. We've actually said no to some other universities because they want to arrange an online midway assessment and final, which is blocking a number of patient slots, which is then obviously impacting income. So we try and ensure it doesn't impact our ability to take patients on as much as possible. We also put the learning onto the student. So say, we want to know what their learning needs are in advance. We want to know what they're going to be looking up when they're on placement, what they're going to be doing. So they can see from the start that they're going to have to work hard when they're on placement. We expect nothing. We expect them to come with no skills at all, because that's likely what they're going to have. We've had one student recently that spent 7 weeks on a moving and handling placement, following around a moving and handling person at the hospital, because the moving and handling physio had to have a box tick that they take students. So that poor student spent 7 weeks in a moving and handling placement, getting very little input. We also have had students that, will go and work with charities and things, and they're just not getting that much hands-on or any sort of what I would call core physio skills at all. So I think that then opens up for us to be far more flexible. The students, the lengths of placements are varying. We actually sometimes find it's quite good to have 2 students at the same time, which sounds horrendous, but actually they work together and you can give them little projects to do together, which can be quite nice, practicing things on each other, which can work quite well. And we also have had, although we've had some great students, we have had some ones that aren't so good, not in terms of what they've come with, because I think you just expect nothing, but in terms of their expectations on us, as in turning up late, not wanting to do any work. And I think we've got a very much a zero tolerance policy now, that if it's looking like that at week 1, they'll just be asked to go, because we do not have the time and effort to be doing that. If there's somebody that, you know, has got lots of learning needs and wants to work hard, we'll give them lots of work to do, and they can work hard and get through, but not if they can't be prepared to put in the effort. And let me find those next bit. Okay, so what does a student look like when they come on placement and they see patients? Well, a lot of what we do with our students is observational. Now, from what I'll just go through in terms of what that would look like if they're seeing patients with us. And I then got the kind of the fear last week that, oh, we've been doing this for years, maybe this isn't what we should be doing. So I did then check with the university, and I'll go through what the university's comments were on what we actually do. So students will mainly be observational, but they will be engaged in that process. So if there's patients that we know of that are coming in that are well known to clinic, but it's a new thing that they're coming in with, or we've maybe seen them last minute and squeezed them in with something, we'll say, do you mind if the student just goes through and asks some questions for you? So we'll get them to go and kind of practice their subjectives. And that works reasonably well, and often people don't mind that. In terms of objective parts, we'll get them to do part of that objective process. So it might not be the whole thing kind of going through, because that will take up too much time, depending on what stage they are, obviously, in their training. But it might be, you know, what do you see? So is that patient standing there? Tell me what you see posture wise, and ask them to go through that. Or, okay, over to you. Can you take the patient through kind of what you would do, range of movement, or different aspects of that, asking them to actually go through that bit while you're actually there. It's obviously putting the student at ease that this isn't an examination for every single patient that we're through, but it's okay to get it wrong. They will just learn, and we'll do that process together. And then we're expecting them, you know, for instance, from a movement point of view, to see nothing, not the same things that we see, but to talk them through that, what we would see as we would with the patient, so that they can start to learn with their eyes, if you know what I mean, rather than not see anything at all. And then they will be involved in that clinical reasoning process after. So, okay, we found this, we found that, right, what might we do treatment wise, and they will be involved in that process, with them doing more and more of it as it goes on. And then they will take in do parts of the treatment. So it might be, let's say somebody came in with a neck problem, we're going to do some manual work. I'll let them feel it, maybe let them have a feel of what I'm doing, but say, look, at the end of this, we're going to give this patient some exercises. Have a think for a couple of minutes what that might look like, and then tell me what that would be. And then if they come up with some good ideas, great. And it might be, can you take the patient through those exercises? Or it might be, right, if they're quite green, we'll say, right, we'll take them through today, but remember that, because you might be doing that the next time. And then we'll get them to do some of the patient notes as well. And we will then look through that and sign it off. But that gives me a really good idea if that student is with me or not, because their clinical reasoning on paper will be horrendous, if they haven't actually gone through that process. So can they pick the good parts of that out, the important parts, and actually put that down, prioritize, make a plan, or are they unable to do that, which means all their nodding was fruitless and there's nothing going on between the ears. If we have, again, some patients, and maybe later on in the placement, and we have some patients that are kind of known to clinic and who like telling their story, we'll maybe get them to be with the student on their own. On the whole, that's what it will look like with the patients that they actually have. Now, as I've said, I got a bit of the fear with this, that there wasn't enough there that the patients were actually doing. But I then recalled my own elective placement in the late 90s in Australia, when that's what that placement looked like. And that was the placement I learned the most from, because I actually could get into my educator's brain as opposed to try and puddle through and figure it out all for myself. And what the university had actually said to me, it's important that students have a range of different learning experiences. So they will have those placements where they do it all themselves. But they said what I had described, which I've just described to yourselves, is, and I'll quote the head of school on this, educationally, this is spot on. In fact, could be considered optimal in terms of cognitive aspects of reasoning, justification, and depth of application of the theory to practice. And they would actively support this approach. And she said that what their goal is in any sort of student placements is excellence and person-centered care is the goal. And I think that does cover that. It is get them to see what good physio actually does look like and how we reason things through. And as such said, would support that approach. And we have, for our not very junior members of staff, but our junior members of staff will take students. So that is part of their role. And then the students will also engage with the more junior members of staff in terms of education as well. So there's lots of CPD going on. We also get them to do some sort of social media project for us, so which they're often far more inventive than we are, and far more in touch with current technologies. And also we get them to engage then with the school, which then helps us from a recruitment point of view. And we also look at this as a 5-6 week basically interview. And if they're good and if they're applying themselves, then we will then often look to take them on graduating. And we've done this numerous times now, and it works very well for us. We recently took on somebody at Christmas, one of the MSCs, who was on placement before Christmas, and she's hit the ground running and is doing very, very well. Yes, needs still a lot of mentorship, but she knew exactly what she was coming into, which was helpful. So that's what we do from a student point of view, and we've probably been doing that for the best part of 16 years now, and it worked well for us anyway. Lucy, did you want to share what you do? Because I loved listening to you.
Sure. I was just going to ask you, Karen, what about finance here? Do you receive finance from the university, and how much? And does it vary university to university?
No, that's really interesting, because that's one of my points to bring up with this going forward. We received nothing. We received no finance. However, we took a student from the college down the road to do a bit of sports and exercise things in clinic, which basically was they hung around clinic for a few weeks and didn't do very much, and we received money from the college for them. So it's interesting. I do believe the hospitals receive funding from somewhere for students. So I do think that is something that the CSP need to bring up, or we need to bring up with the universities, that, particularly for these overseas students, they will be receiving a lot of funding for them. and you know, what does that look like if we're going to be involved in that education process?
Brunel
just on that. Sorry, go ahead.
Brunel informed me that apparently the fee is set nationally in Britain anyway, I suppose, as England, sorry, as £650, and it sounded, reading between the lines, is that they would actually be willing to offer more to clinics, but that figure is set by Education England or something, is what Brunel told me.
Actually, just on that point, we had a student from Northumbria University in July, August last year, and we assumed, because we'd had a student from our local university before and been told that we didn't receive any funding, but then after the student had left, a couple months later, received a check for about
I'm going to go out afterwards.
It's no surprise there, Rachel, that we're the poor brothers and sisters and here not receiving any money.
Yeah, well, it was just that when the check arrived from Northumbria, I was like, I didn't know what it, you know, it kind of took me a while to put two and two together that they had paid us for the student placement when we'd always been told previously there was no funding for private practices, but the hospitals did get funding. So I don't know if that's changed.
I'm not aware. That's certainly not changed up in Scotland, but I've got no idea anywhere else. That's really interesting, actually, that you get paid in England.
Yeah, I mean, certainly I got paid for mine. So, and I think that's universal. I think that was made very clear at the beginning. So I'm just going to talk to you a bit about what we did. So we take master's students, or we always used to, never took any undergraduate students. And I just had an incident when one guy from UEL, who's at University of East Anglia, got in touch with the clinic and asked to do a placement with me. And I just assumed, okay, well, he must have a girlfriend or a brother or somebody who lives in Clapham and just thinks that this is going to be nice and cushy. And that wasn't the case at all. I spoke to him on the phone because he'd got through the gatekeeper, and he said that he'd done his last essay on facet joints, and could he send it to me? And I said, yes, of course. So he sent it to me, and it was really good. He obviously knew what he was talking about. So I said, right, when do you want to do the placement? Now this was, he said, next year in January, I want to be with you for 10 weeks, I think it was, 8 to 10 weeks. So I said, okay, well, if you can come up and meet me at Easter and bring everything from the university so I know exactly what's required of me, then I'll be able to say yes or no on that day. So he was good enough to come up. His essay was very good, like I said, so it was quite impressive for an undergrad. I clearly wanted to be here. Said he didn't have a girlfriend or an uncle or anything. I said, where was he going to live? And he said he knew somebody who lived outside London and he was going to commute in. So I said, okay, fine, fair enough, let's go for it. I can remember a fee. I think it was probably £500 to £600, something like that. I don't think it was tons, but it was certainly.
No, I don't know.
That sounds like Rachel.
Nicola, you need to go to mute.
That's it. She's done it now. Brilliant. Okay. Anyway, so we did things slightly differently because I thought this guy was really serious about the spinal pain, which he was absolutely at the time. And so I went to our local GP and said, can you send us some patients, essentially, from your back pain list for anyone who's not getting any NHS physio, anyone who's got, you know, the acute backs, the worst backs, blah, blah, blah. And we will guarantee that for those 8 weeks, they will get very good treatment. They'll all be supervised by me, but they'll be treated by a student, and everyone needs to know that. And then we have a duty of care, so we'll carry on treating them after that week, but after the placement. But the whole idea is that they will get mostly treated from that, and that's what we did. So the GPs obviously went, oh, it's Christmas, and poof, this is chucked us loads of patients, which I knew they would do, but I really didn't mind that. So we didn't charge them anything. We also well, when we've done this before, we go to the team who work here and say, any family, friends, you know, anyone who's not getting treatment anywhere, back pain, chuck them to us and we'll put them on the student list. So essentially, we treat it as a good PR, a goodwill exercise more than anything else. And essentially, my attitude was, I don't want to treat anybody. I won't take on anyone who's not 100% thinking that they really want to get interested in the spines, that they're not 100% dedicated. So anyone just doing a tick box, not interested at all. So yeah, this guy was very good, really nice, got on well, not universally well with everybody. You know, a couple of people thought it was really, really hard work, and he was very hard work. And I must say, we were used to master students and hadn't taken on any for a while. And yes, it was hard work. And we got a big enough team, so I spread it around, and you know, everybody did their bit. Everybody who was employed, that is, did their bit.
Have you done it again since, Lucy?
No, I haven't. I haven't, largely because I haven't been approached by anyone. So I never have to turn anyone away. But if somebody approached me like that again, I would say yes. I mean, the end result was we had a very good placement. He was very good. We actually managed to recoup some money, essentially because we knew by this stage that he was really pretty good. He was very trainable, very teachable, very personable. And patients that we'd seen together, or patients who had run out of their PMIs, we then offered Joe, his name was Joe, we offered him half price for the sort of end of his placements. And there were certain things he could do around the clinic to kind of compensate a little bit, like, you know, we taught him the Alter G, putting people on the Alter G, we charged 50 quid. So there were a few things like that he could do when he wasn't actually treating, but the majority of the time he was just going back after back after back after back, and they got really good treatment. And I think we only ended up with one person after he'd finished, and we offered him a 4-year internship. We did it on our intern program, which he took, and he stayed with us for 5 years. So from that point of view, I knew that I wanted him to stay because I thought he was really good. He was heavily into spines, and was very trainable. So
did all the supervision end up costing you money though?
Absolutely, yes. In terms of lost income, absolutely, yes.
Yeah, I mean, that's a massive negative for us, isn't it? It's just
you're absolutely right, but you don't have any, you know, you don't have any fees to recruiters, you don't have any advertising fees, you know, and we've got somebody who we know exactly what he is. So I when we start our intern program, we do quite, like, we've had a new guy on the intern who started in when was it, October, and he's so far, where are we, we're May, so far he's passed his lower limb, running, cycling. He's still on spines, so he doesn't see spines yet. He was 2.5 years qualified and a year as a senior in the NHS before he came to us. And it's easier having somebody like him because you don't have to teach him basic patient interaction. However, you know,
so who's this? This is a graduate physio.
This is a graduate who has done 2.5 years in the NHS, 1 year as a senior in MSK before he came to us. And he was, you know, he failed. We knew he would fail his practical. So whereas a Joe at the end of his 8-week placement was as good as some of my junior spinal physios. And I thought, you know, I'm not turning this guy away. And I didn't have to train him at all. He went to our, but he was mostly, and he was very quick to learn. And I knew he'd be very quick to learn. He was, because he had done so well. So I completely endorse what Karen says. It really is a great interview. But I wouldn't, I don't want to take anyone who's just going, oh God, and now I'm going down to balance for 8 weeks. That's boring. We don't have those kind of resources at all. But that guy was quite special. And
I think the trouble is what the universities are looking for is regular placements. And,
yeah,
you know,
absolutely.
One individual, you know, so if bigger practices or even smaller practices can take on one student permanently almost, so the rotation of them, that's going to help. I mean, these universities shouldn't have such enormous amounts of students needing placements, I don't think. They should have done that before. But but if we, I mean, I think the biggest thing is the worry about the cost and the impact on the physios that are training them, And much more obviously is the patient saying, well, I'm paying privately, I don't want to see somebody who doesn't know what they're doing.
Yeah, no, exactly. That's why. That's why we took. We didn't feel we could charge anyone, but we could. We did have a half price fee for family and friends after a few weeks when we realised he was pretty good. And we said they would be then supervised by me and I would take them on if they weren't better at the end of his placement. So we recouped a little bit. And I've got a figure of about 500 or 600 quid in my head that the university paid us, which is, you know, obviously less than a day's income. But, you know, it's not a money making exercise, but, you know, 4 to 5 years of him staying in London was enough recompense.
And the positive as well is that the GP knew all about you, and therefore hopefully you might have got more referrals to the private.
Yeah, and I mean they're good supporters of us, so it's nice to give something back to them, really. I think that's everything I had to say. I must say that the only other thing I wanted to say was that on our intern program, we changed all of that. We went through the whole lot with our lawyers before this recent one, because all of the laws have changed around that. And effectively what they said was, because we have a kind of payback clause if people leave before, take all their training after 1 year. And what the lawyers were very, very keen for us to correctly account was that when the interns, so the qualified physios, are receiving one-to-one training, you can't put any value on that, any monetary value on that. You can only put monetary value on when you are not seeing a patient and you are spending your time with them. That was essentially what they said. So you can, they told us to only write an internship for 2 years, not 4, and that they said we've got to display a period of intense learning followed by a period of intense practice, and we can charge for all of the practice but not the learning. So we rewrote all of our before last summer, all of the contracts for this, just so that we were up to date. And these were the lawyers at in the Federation of Small Businesses, so it didn't cost us anything, but they were very, very uber helpful about looking at our contracts for graduates and people starting on that kind of, and how we would be able to get recompense and when we would be able to get recompense and what for. So it was quite involved, but I'm happy to share that with anyone because it took a very long time. And like I said, it only cost us time, but it's quite robust now, according to the employment laws of last summer. Yeah, so I think that's it. We have fairly strict guidelines for work experience, which is essentially we say yes to anyone who asks us for work experience, but they have to come in and be supervised by the person who's introduced them to the clinic. So if it's one physio saying, you know, my mate so-and-so 17-year-old wants to come and do work experience, we say, yes, you've got to organise it, i.e. you speak to the podiatrist and the soft tissue therapist and the whatever. We won't have anyone under the age of 16, and we won't have anyone who is not going to get the qualifications for physiotherapy. So anybody who is looking at doing physiology or any other aspect of healthcare but wants to come, we say no to completely. So it's only those who are considering physiotherapy. And that's it. So yes, I would do it again if I had somebody who I thought was quite exceptional or dedicated, or, you know, I wanted to live in a tent on Clapham Common so that they could come and be here for 8 weeks.
I don't know if we're going to get a choice if we open the door, though, are we?
No, I know.
We either do it or we don't we?
We do say, Tash, I was saying at the start, we make all our students apply to come to us, and we only say yes if we like what they write on the application form, because we don't have time for passengers people who actually be here. And this is maybe where it might even, I mean, where is it going to go with physio? I don't think any of us obviously know, but is there going to be a little bit of an NHS and private divide? And is it that it's the students who want to actually potentially work in private practice that are then going to come to us?
my understanding was, but Amy, you can fill us in when Brunel spoke to you, is that they're looking for placements for their students, irrespective of what those students want to do. You don't really know going forward either, do you? You think you want to be NHS probably, but what did they say to you, Amy?
Well, I think they're just desperate. I mean, they've got 200. So across their 3-year BSc and 2-year MSc, all of those students have got to do placements this summer, either beginning of summer or like end of August and September. That amounts to hundreds of people, and they've got X number of hundreds sorted. They've still got 200 to go. I mean, it's a lot of placements. They don't care where these students go. In my opinion, they just need them placed. You know.
No, but what they do care is they care about the people who are taking them, as in they don't want to annoy them, because if you have a bad experience, you won't take them back. So potentially from there, you can say, yes, we will, but it needs to be somebody who wants to potentially work in private practice after they graduate or has a strong interest in MSK. We won't take anyone other than that. And I think we can stipulate we're the ones that, you know, they want us, and our university locally has been really good from that perspective. They know that, well, they don't want to annoy us, but we only take the electives at the moment, because the paperwork is far less. It's just pass fail.
I love the idea of offering free physio to these GPs, though. I think that could be good, but it's the supervision costs that worry me. Because certainly my private patients would not want to see a student.
No, sure. My private patients wouldn't want to be see a student. The
I
beauty
wouldn't
of
want to.
the beauty of taking NHS patients is that the physio, you know, I said to him, you can see them 4 days a week. You can see them 5 times a week. I don't mind. They can be in the doing exercise this time, doing whatever this time. Just make them better by the time you go. Okay, that's the. I don't want to see these people. Okay, and that frees you up a little bit once you know it's safe, etc., etc. Then yeah, it does work. It did work quite well.
We like I said, had a student back in July, August last year. We did, although we didn't approach the GPs, we did send a message out to our database saying that we had a student on board and that we were looking for people to come in for free treatment. And more specifically, it was kind of a, do you know somebody who hasn't been able to access physio? So it was more asking our database to refer somebody, and that it would be free of charge, which did work out well. But I do agree it was the supervision time that was the issue, and the amount of work that went into that really, because I don't work clinically anymore, I was able to have the time to do that. But my concern, and to be quite honest, after that placement, I said we're not doing that again, because the amount of work that it needed wasn't worth it at the end of the day. Now, but Karen, I'm really interested in what you were talking about in saying about how, you know, they're observational in the assessment, and we did it, like so much of it was observational with us. Did you need to lengthen out your treatment times or your assessment times to allow that, or you just did that all within your sort of normal allocated time? Yeah.
And all within the normal allocated time. And then, you know, we encourage the physios to say, look, you know, you get notes time as well in the day. So if you run over with bits because it is a little bit longer, then get the students to write the notes, you check it, and then you sign it. So you're signing it off, but get them to do that aspect. Yeah. Or if there's exercises, you know, that they go through, they go through that at the end of the treatment while you're then sorting other bits out. So it's obviously a little bit harder work to begin with, but by the end of the treatment, by the end of the placement, it should be that student is actually more helpful. And the only time that was therefore blocked in the diaries was for the midway and for the final, but now we try and encourage them to do that in a free slot. So it's not actually costing us any money. And we find that a lot of the patients actually like being part of a learning experience. Mm-hmm. Obviously, they know that we're still in charge of it, so they're not shortchanged. And if, let's say, they've got a left-sided neck problem and we're doing something with it, we'll sometimes say, do you mind if the student just kind of works on the right side of your neck or something, do you know, so they feel like they're getting something more. which they sometimes enjoy. But I had a hospital appointment a few months ago, and they'd said, do you mind if the student kind of sees what you're doing? And I actually felt quite good being part of a kind of student experience. And I think obviously not all our patients want to be involved, but I think some of them, knowing that it's that you're teaching, that you're actually good enough to be in their hands, they actually quite enjoy the experience.
Yeah, I agree with that. I think it does sort of set you apart maybe slightly in terms of being the ones that are teaching. The other question I had, Karen, was about, you were talking about how they expect to do a lot of self-directed learning. Do you guide that in any way? So, and that kind of ties in with Lucy. I know we've talked about your internship before, but I'd love to find out a little bit more about it. So Karen, from their self-directed learning, do you have an outline of sort of going, right, here's the things that you need to go and learn about, or does that come naturally from, say, they're sitting in an assessment and somebody comes in with a...
Yeah, it's more around what they're seeing and what they don't know. So it's that learning associated with practice to get that kind of deeper learning. So if they come across a frozen shoulder and they've no idea what that's about, then learning about it. So they're learning about the things that they're seeing, so they can maybe try and kind of hang more pegs on that knowledge. We also normally share the student between two physios, so that they're not getting a student 5 days a week. So they're maybe 2 days of the student or 3 days of the student, so that they're getting a bit of breathing space. Because I mean, it's great when they ask questions, but my word, you're knackered by the end of the day. So yeah, sharing that experience as well. But there's some awful experiences they're telling us about these days, which just makes my toes curdle. No, stomach curdle and my toes curdle.
I'd like to see that.
Yeah. And Lucy, how do you structure your internship? So when they come on, I know you were saying it's a 2-year. So do you cover it by, like you're talking about, lower limb? And they have specific things and topics, and then they're tested on it?
Yeah, exactly. We take 100% of their time. And so their whole diary is structured for learning, intense learning, one-to-one, observation, reflective time, practical skills, practice, blah, 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 blah. Time with podiatrist, time with this. So first of all, they did lower limb. So it's foot and ankle, lots of time with podiatry, lots of time with, so foot and ankle ran alongside the cycling module, and then knee ran alongside the running module, and hip, lower limb. So he's been signed off on all that. So gets a real patient and 2 physios being, he's a nice guy. Everyone likes him. They go, right, yeah, get out our time today. Spine, we haven't signed him off on the spine. He's a bit slow on the spine, so he's been doing the spine for a while, and then he's onto upper limb. So it's pretty time consuming, but we've had weeks when we've had he's cost neutral. He was probably cost neutral from December, and we've had weeks when we're making some serious dosh out of him when he's busy. At the moment, that's how it goes. So he's seen probably on average 20 to 25 patients a week, with plenty of reflective time. He's 40 hours a week. So that's kind of where we are at the moment. It's very easy for him to see multiple patients. Most of his patients are all PMIs at the moment. So soon as he basically changed, his contract changes in July, where he does 3 Saturdays in 4. So for then, that's our target of him being absolutely competent in everything. Now, bearing in mind, he'd done 2.5 years anyway, and a year a senior post in an outpatients in the NHS. But he arrived with no skills at all that you consider. So he's pretty good. He's pretty good. He's a quiet, he gets on with everyone, which is really nice. He's a very quiet gentleman, and he doesn't think he's very good. I think he now thinks he's probably half good. So he's got a nice attitude to learning, and he's easy to teach. Yeah, so that's effectively how we structure it. It's completely structured, and from the word go, he knows what his year looks like. And then payment wise, we pay him a lot, so he gets paid well to learn. I think his salary in his first year was 40 odd. When I say 40 odd, I mean 40 low, 40, 41, something like that. So it's a big loss for us to begin with, but we will make money out of him in the whole of the first year. It's just not that much.
Bloody hell, can I have a job with you, Lucy?
Yeah. You can teach us, Tash. And then he's massively incentivized to stay. So there's big step ups in his salary between year 3 and year 4. It goes up. So it goes up at 6 months, and then it goes up after year 1, year 2, year. We've done that with all of our interns. I think the first one we ever did, we basically made sure that it was at every stage it was about £5,000 more than if they stayed in the NHS to begin with. So there was real benefit for them being out of the NHS. At that point, when we first started doing it, the NHS was still a good training ground. You still got a good experience in outpatient departments, and that's not the case anymore. So no, he's having a lovely time.
And do you have your learning set up on like an online database, or is this all?
So Sophia has done the whole thing in conjunction with 2 others in the team. One's quite experienced at teaching undergrads anyway, and really likes it. So that was, when he arrived, we thought, oh great, he can do some of that. And it's not all online. But it's the structure of it is all what's the word? Timetabled. So he knows a month in advance what he's doing. The whoever's involved know exactly what they're doing. The exam comes along. He knows who's examining him. I try and keep out of it as much as possible, and I share the spinal with 2 others, essentially, with him. So, yeah, that's basically how it goes. And the beauty of this is difficulty with recruitment at the moment. We always do a practical exam for everyone, and if they fail it, we just say cheerio. Sometimes they fail it. If they have a sports bent, we make them do spines. If they have a spines bent, we make them do sports, and then we work out in the most least threatening way what they're bad at, because anything's going to walk through the door, and then we structure around that. So if people have too much time, if they're going to cost us a lot of input, if they're really clearly got poor hands, we just say cheerio. We've offered internships to people who have failed, come along for weekend jobs, but looked good on paper, 8, 9, 10 years qualified, but absolutely shocking hands. So we've,
it's a student. It's the company dog.
So yeah, so it's very structured. They know exactly how much time they're getting. They know exactly what they're learning. Roughly, it's 20 hours learning a week input from us, and 20 hours from them. And in the early days, that's a lot of their time is spent preparing or reflective or looking at various things. And we get a bit of money off them in the early days, but not very much. So
we have internships as well, but ours isn't as structured. But it's funny, the time that they're treating versus the time that they're learning is about the same. They start with about 20 patients a week, so 4 patients a day, then go to 5 patients, 6 patients, 7, and then they work up from there depending on what they're able to do. But we sit down at the start and look what their learning needs are, and they have a mentoring session every day that's in the diary, and then that goes to 3 times a week, then twice a week, and once a week as the support comes off. But the learning's directed by them. I'm not as generous pay wise, Lucy. We pay them the same as a new grad would get paid in the NHS, because the learning costs us a small fortune. But we then get the payback from once they're a little bit more competent. So when they're kind of 4 patients a day, they're costing us, but very quickly we'll start to make some money out of them. We don't tie them into anything legally, but we sit down with them, look them in the eye, and say, unless you want to stay for 2 years, this costs us a small fortune to do this. We will invest in you, but we need you to say that you're going to stay with us for 2 years. What you do after that is entirely up to you. But we then try and be super nice to them, know that they stay. and that's worked well for us. We find take them from the NHS and they're de-skilled, and we've had a few conversations lately with people, and we say, you know, if MSK and the private sector is an interest, come straight from uni. We'll train you up there, and then they don't cost us any money. Well, they do, but if they're kind of suddenly coming from a band 6 or, you know, role, then suddenly they're costing you a lot of money, where you actually have to retrain and get rid of bad habits, whilst then training. So the training we feel is actually harder. So yeah, it's slightly different, probably a little bit, well, it is less unstructured, but they structure it is driven by them.
I think the reason we went down the lawyer route was, you know, we've had some great successes of people. Our longest lasted for 8 years, and we've had 2 people who left after 1 11 months and 1 12 months. So basically took all the learning, and that's partly.
Barry, is it? Yeah.
I wouldn't really blame those individuals, because we have, you know, we have a lot of people trying to poach our staff, and you know, we've lost quite a few. 2 other lovely members of this organisation, I must say. But here I get out. Not here to.
Not me.
No, not you, sweetheart. Yeah, no, you still get a gold sticker for me. But no, well, I don't blame it. That's fine, you know. And people are, you know, that happens. But the one thing that it did do was the contract went back and forth and back and forth and back and forth. So we know that this guy was really thinking about, and he was saying to us, so if I leave at 2 years, that means I've got to pay you this and this. And we said yes. And if I leave at 3 years, then I've only got to pay this. And if I leave at 4 years, I've got to pay nothing, correct? And if I leave after 12 months, what happens if I have a car accident and I'm in hospital for a year? I said, we are not going to, you know, we're not going to chase you down. I made him really think about all these issues. And I think that comforted us a bit more, because it is so expensive when somebody disappears after 12 months. You know, you might have broken even on them, but that's not the intention when you've put in so much effort into somebody. And we're never going to chase them down. I mean, we're never going to spend 30 grand at solicitors chasing people for money back, are we? Come on, you know, that's the bottom line here. So we just want to get something as robust as enough so that we know that somebody is invested and is going to stay. Because this is London, it's very competitive, and there's plenty of people offering, you know, nice. You think we're generous, Tash? There's plenty of people offering more money than we can afford, I assure you. I know.
Listen, I'm going to meet the CSP with Simon on Wednesday next week, with new chairman, to have a chat and see how. Did everyone see? There was a recent thing from the CSP about how they're looking after private practice visits, which is good. I think that's positive. I mean, there wasn't much information, but at least they're looking at it. And is there any question I should definitely ask them about student placements? Because of the fact that, you know, it's going to cost money, it's going to take a lot of time, and it's going to take some structure. But I think that it's the fundamental feeling that yes, we can do it, but we're not at the detriment of our business.
I think the first thing that I always think is that because we've had very good experience, we understand how difficult it is in the NHS, and it's not just that they are, you know, chucking out many more patients. It's just that people are not getting hands-on therapy. So we would like to support our profession in getting very good placements. So I think I would be very happy to take regular people if it was, you know,
we've just got a structure.
Well structured, and I've got good people.
And I would think as well, you know, could they create a focus group that actually looked at that, as opposed to the universities engaging with the CSP, you know, nothing. So could they almost, the CSP kind of push that out a bit to some, you know, like this group here, and say, what does that look like, and what would we need, what, you know, to make it work for us and to work for the students, what does that look like? Because I think anybody who's taking students is invested in helping them, but it's looking at how they can work with us to ensure it's not to our detriment, because then the whole thing's going to fall apart.
Yeah, absolutely. But it's true that they're not getting great training in the NHS either. If they're just being trained to give someone exercises on a sheet, It's pretty shit.
And
I've got to go, I'm afraid. But if anyone does think of anyone they want us to ask the new chairman, just email or put it on the group.
Super. Thank you,
Thanks,
Tash.
everybody. Bye.
And any other questions on the back of our discussion today? I hope that was useful and given some insight into, you know, how myself and kind of Lucy do things with students, and then follow on from an intern perspective. If there is any further questions, I know I'm speaking for you here, Lucy. I'm sure we're happy to kind of take any questions about that or follow on from this, because it's linked to kind of getting the future new grads in the door and working and sustaining our practices kind of longer term.
Karen, actually, sorry, one question I would have. Would you be willing to share your application form that you get the students to fill in, or, you know, a performer of something like that? I'd just be interested to see what specifically you're asking, or where you're wording it.
Made it up, but I can certainly ask. Leslie has that information, and knowing her, it'll be reasonably detailed.
That's great. Thank you.
Okay. Thank you very much for your time today. Appreciate you inputting, and have a nice rest of your day. And thank you, Lucy, for your input.
No, that's all. Thank you. Bye-bye.
Okay.
Bye.
Thank you. Bye-bye.